Right, Christina, are you happy for me to start now?
I think it's a good time to start. Yeah, people can
Okay,
join in. Yeah,
as they
thank
come
you.
in. Okay, thank you so much.
I think you've just gone on mute, Andrea. Technology.
Yeah, thank you, Christina. Good afternoon, everyone, and welcome to today's Respiratory Matters webinar, and thank you for joining us. For those I have not met before, I'm Andrea Pace, the Assistant Manager for the National Clinical Strategic Network for Respiratory Conditions. And if you joined us last month, you may remember that we focused on asthma care in children. The feedback from the session was brilliant and it sparked great discussion. So today's topic follows on nicely, shifting the focus to asthma care in adults and how to bring the new BTS sign and NICE asthma guidelines into everyday practice. Each month we try to keep these sessions relevant, interesting and practical, and we aim to continually improve the webinars, and we really appreciate if you could just take a few minutes to fill out the survey that we've posted in the chat, and this will ensure we continue to deliver educational sessions that are relevant to you and your teams. So before we start, there's just a few housekeeping points. If you could please keep your microphone muted and camera off during the session. The webinar is being recorded and you will find the recording later today on the Respiratory Matters Teams channel, and the link is in the chat, and it will also be uploaded to our website. If you have any questions at any point, please add them to the chat and we will try to cover as many as we can during the Q&A session at the end. If we do not get to them today, they will be included in a written summary that will be circulated. So today we're diving into the BTS sign and NICE 2024 asthma guidelines with focus on what they mean in practice for adults. We are really pleased to have Frances Barrett with us to lead this session today. Frances is a respiratory and spirometry trainer with a background in nursing and education. Frances, thank you so much for being here today, and I'll hand over to you.
Thank you very much, Andrea, and indeed to Nick and Christina who are in the background as well. I just want to, if I can get this to work for me, which I hope it will. Now, where has it gone? Bear with me 1 wee second. We'll see if I'm doing something that I wasn't doing in the earlier. No, that's that up there.
It's always the same, isn't it?
It most certainly is. It most certainly is. Just bear with me 1 wee second, just to see if I can do something different. Sharing. All right. Share. Oh, found it. Don't ask me what was doing. It was hiding. Now, I'm glad, Andrea, didn't say I was a technical nerd on top of what you've just said there, because that would totally have been incorrect. So I have a very short window of time, and I want to thank, as I said, the team there for offering me this opportunity to share with you my insights into the new BTS sign NICE guidelines that were launched on the 27th of November last year. I know that you've covered the pediatric end of the asthma guidelines last week or the week before, and therefore I'm not going to labour that. Now, I have included them in this presentation more for completeness than anything. So this presentation in its PDF format will be available for you to download, or for you to use and use for your own learning in the future. And I'm also going to skip over the likes of pathobiology and things like that. But as I say, it's just really for you to have that sort of putting everything into the context of the whole broad sort of base, if you want, for asthma. So my name's Frances Barrett. I've been around a long time. You probably know by my face. If you can see me, I've now lost use, but if you can see me, you'll know I've been around for a while. From 1988 in general practice, and really focused in cardiology and respiratory for all those years. I'm not going to labour these here because you're going to be able to read these yourself, but just to really flag, if you like, Gina announced back in 2024 that really it was a global health problem, asthma, and it's affecting 300 million people across the world, causing about 900 deaths per day. Now, that's a massive, massive burden on all the different various health boards and health sort of environment, if you like, across the globe. But the reality is, and we really need to focus on this, and I did my asthma diploma through Education for Health, or NRTC as it was back in the day, in 2000. And in fact, it was even before that, but I had to learn stats for that there in the 1998, I think was the last stat that was available for that particular cohort of that I was doing my study under. And there was 1,600 and something deaths that particular year across the UK. And in 2017, there were 1,470 deaths. And there was innovative medicines, innovative devices. There was the cough, and I'm saying that with tongue in cheek, that really was there to drive better outcomes for these asthmatic patients. And really, things were getting no better in terms of mortality. So something big had to be done. There's and you can look up this particular young girl herself, Rachel Williamson. Her daddy, Simon Williamson, approached us back about maybe 2000, just at the start of COVID, to really see how we could make a difference to asthma mortality in Northern Ireland. This wee girl was 16, and back in 2017, when she died suddenly from having mild asthma. She died in the middle of the night in her home in Portavogie. Tragic, and on the death certificate said catastrophic asthma attack. So I'm sure you have your own stories to tell in Wales, but the problem is that we really need to be sitting back and thinking about how we are going to mitigate against that. So the new BTS Sign NICE guidelines has been the most massive seismic change from I started in my general practice in 1988. Now, we know there's the last data point back in 2017 announced there were 40 deaths in Northern Ireland. We have to really sit down and think about why this is keeping recurring, and there's lots of factors that influence that mortality status. But also morbidity is another big thing, which you haven't probably honed in on enough in this presentation. But this is just a wee bit of state of the nation. Just good to know, 5.4 million people in the UK. And that's not global, that's just UK, 300 million globally, but 5.4 million are living with asthma in the UK. Every 10 seconds across the UK, someone is having a potentially life-threatening asthma attack. And there are the families of three families are devastated by the loss of a loved one every day in the UK because of asthma. Yet over 2/3 of these deaths are preventable. So I had to really think about what the underlying causative factor might be. So a massive deep dive into what was causing this to continue at the rate it was. There were shocking statistics and shocking reports out there, not least the NRAD report that came out in 2014 that really hit home hard for all of us that have been around for a long time, thinking, why were these 195 deaths still occurring, and the potential of 80+% of those were avoidable. So really it's been shocking, the statistics. I'm going to just flag two things on this. The NICE guidelines and the NICE definition for asthma is airway inflammation and hyperresponsiveness. Now I want you to keep that to the forefront of your mind. Inflammation and bronchial hyperresponsiveness or reactivity. It does cause variable and intermittent symptoms such as shortness of breath, cough, wheeze, chest tightness, chest pain. Those things are intermittent and variable and provoked by triggers, and therein lies an issue in its own right. And patients and healthcare professionals like ourselves can get lured into a false sense of security. Sorry, I just skipped on 2 slides there by mistake. The GINA didn't define it any differently, really. They have also, this is the global definition, they have said chronic inflammation is the underlying pathobiology of asthma. And I'm not going to labour that anymore because there are slides on it that will explain that in great detail, of which I really don't have time to go through today in this very narrow window of being able to share with you my thoughts. But just keep these two things in your mind, that chronic airway inflammation and bronchial hyperreactivity or responsiveness are the two key factors in the underlying pathobiology of asthma. And it gives rise to variable episodic symptoms. I'm not going to go through any of this here, so bear with me just on this here. I'll just put it all together so that you can actually reflect back on that and build your own understanding, your own knowledge base whenever you read through this presentation later. Diagnosing asthma is perhaps been the biggest challenge that we have ever had to face in any disease state. If you look at COPD, you get fixed airflow obstruction, i.e. ratio lower than the Z score of minus 1.645 or less than their lower limits of normal, or in old money, less than 70%, which of course we're verging away from. In diabetes, you've got your HbA1c, and it's a cutoff. If there's the likes of raised lipids, you've got cutoff figures and you know exactly where you are. Blood pressure is the same. Think about asthma. What have we got? We had got very, very little. Every time you bring a patient in who's been symptomatic yesterday or resolved today, just the very nature of the disease, symptoms vary, and then vary intensity, etc. The Asthma and Lung UK brought out a report that actually was shocking. It was absolutely shocking. It said there's abysmal lack of testing for lung conditions, and this forcing GPs, and dare I say, nurse practitioners like myself or other allied healthcare professionals to play a guessing game with the diagnosis. Please read that report. It would make your hair stand. It was so upsetting to read that there, to think that actually we have got very poor testing facilities for respiratory and not least for asthma. But as I mentioned earlier, the lack of biomarkers up until recently, poor QOF targets and poor understanding of the underlying etiology of asthma has led to very poor diagnostics. A lot of patients have been diagnosed with asthma that may actually not have asthma at all, or people that should have been diagnosed with asthma have missed that golden opportunity of being diagnosed. And patients then are lured into this sort of perpetuating a situation where they think they're getting recurrent colds, or they're getting recurrent chest infections, or their wee child has got something else going on, where in actual fact is unmanaged and undiagnosed asthma. This is the sort of state of play, and I've been doing this. I did this actually for PCRS recently, and they're going to be using this kind of picture to show the abysmal approach to asthma diagnosis. And that's where it all starts, getting that diagnosis perfect at the time of the patient presenting, and stop this guesswork. We have an ability to reduce overarching costs and unscheduled visits, amongst many, many other things, and really clean up this. I'm not going to labor this because I'm going to let you read this yourselves in the essence of time. But the atopic or T2 positive asthma's like a bit like diabetes. It used to be you had diabetes, and now then you had type 1 and then type 2, and now there's subsets of the type 2s and the type 1s, etc. So we now know that everybody has a different sort of underlying etiology or biology that can give different nuances, if you like, to these disease presentations and manifestations. So we know that if patients have got T2 positive, i.e. eosinophilic or atopic or allergic type asthma, that they can be identified early on in that disease presentation. And therefore you can do it through the recognized biomarkers now, i.e. eosinophils, or through pheno testing. You can also do the likes of RAS tests and all those kind of things too, but I'll talk a wee bit about that down the line. The non-T2s may be the bigger challenge, and although they're a smaller cohort, and you might look for older presentations that hadn't had any childhood presentation. They may have blocked noses with likes of polyps and marked rhinosinusitis, and they may have sensitivities to the likes of aspirins and other non-steroidal anti-inflammatory drugs as well. So you might think about those kind of people as being non-T2 positive or T2 negative, whatever way you want to say that. But those kind of people may not have raised eosinophils, etc. I'm not going to go through all of this because this would take me all day. And other things just to keep in your mind at all times. Remember, the airway doesn't start at the oral pharyngeal junction. It starts at the tip of the nose and works its way down. And we do know that the nose can impact the airways just like they can impact the eyes, because you've got this thing called nasal bronchial reflex and nasal ocular reflex. And people like myself who are allergic to everything is a nasal bronchial and a nasal ocular reflex. So I have runny eyes in the summertime and bad chest, etc. So you do need to think about that. But also don't forget about reflux. If you're asking patients about things, always ask them about reflux as well. And this is just a good picture to tell you that when patients' symptoms become visible, i.e. they're aware of them, there's an awful lot that's gone on underneath the surface, i.e. bronchial hyperreactivity, airway inflammation, and airway remodeling. And we need to keep that at the forefront of our mind. Patients will maybe be totally unaware of that, and they'll only come to you when they have breakthrough symptoms. So asthma, I just want to put that out there, is more complex than what we might think. So along comes the BTS saying NICE guidelines published on the 27th of November last year. And I'm going to say that it was the most welcome set of guidelines in my whole career. And I was really, I suppose, very privileged to have been on the consultation panel, and what came out at the very end actually surprised me a wee bit, in that peak flow was still brought in. In the consultation document, there was no peak flow. I'm just putting that out there because I can safely say to you, over the next number of years and changes of guidelines, that the likes of the peak flow will ebb out of it. And there's a very good reason for that there. So what they tell you is, you really start with physical examination. I'm going to put it out to each of every one of you. If you went to your local healthcare practitioner, let it be a GP, practice nurse, nurse practitioner, a pharmacist, or other allied professional, you were complaining of a chest issue, you would want them to look at your chest. It's just a basic need. And we do need to be looking at the patient's chest, look at how they're breathing. You could get a curveball. Are they symmetrically rising and falling? Are they chest expansion at a normal size, etc.? And are they using any accessory muscles of respiration? What does their chest look like? And then listen for the sounds to make sure that there's no expiratory polyphonic wheeze. Expiratory widespread polyphonic wheeze is what you should be listening to. There's a wee link there that you can actually click on at some point whenever you're looking at this down the line, and look for what this might sound like if you're new to chest examination. Now, this is what the guidelines also say. We're always caught in a sort of like a rabbit in the headlights. The patient rocks up to you, they're very unwell at time of presentation. You're left with no option but to start initial treatment. Now, if you don't have the likes of an opportunity to take a blood sample from them, or you're not able to do FeNO, which is fractional exhaled nitric oxide, at that point in time, or you can't have a spirometry accessible to you, then you're stuck between a rock and a hard place, because you're really going to have to start treating them to be ethically doing the ethical right thing for the patient, and you're going to miss that golden opportunity of confirming that diagnosis of asthma. And that's what the guidelines are saying. But you have got to treat the patient immediately if they're acutely unwell or highly symptomatic. So you really are going to have to manage that. So what we're saying now is really to try and have a pathway within your practice developed that you're going to be able to do either FeNO if you have it accessible to you, or a blood test to see is their eosinophils elevated, or do spirometry if they're symptomatic at that time. Now, the algorithm for diagnosing asthma in adults and young people over the age of 16 includes blood eosinophils or FeNO at the time of presentation, if at all possible. And I have started that there in the last sort of, I would say, good 9 months now. And honestly, I am surprised. It's really helping me inform my management decisions. Now, I'll give you an example. Twins who have been treated for antibiotics, and these twins are 14 or 15 now, and I did FeNO on them there because I've just managed to get my hands on a FeNO machine, and honestly, I was shocked. Their FeNO was well over 200, both of them. So it really informed my decision making, and it really helped me educate the parent, the mother of those children, because she was totally averse to initially starting anything with steroid in it. So it really helped to inform her as well. So that's where that lies. And eosinophils and the likes of FeNO is the two really number one biomarkers for our older patient cohort, 16 and above. If that's not available to you, you might want to consider spirometry if you've got spirometry accessible to you. And again, you're looking for a bronchodilator reversibility of 200 mils and 12% of the FEV1 from baseline, or 10% or more from the predicted or normal, baseline as well. So if you do a baseline on them and you can get them their FEV1 to go up by 200 mils and 12%, you're fairly sure it's a strong signal towards an asthma diagnosis. Sorry, going back to the eosinophils, and I didn't even mention this. If you have a FeNO for an adult or young person over 16, you are looking for a starting point of 50 parts per billion. If you're getting 50 parts per billion or more, you're fairly confident that that is an eosinophilic T2 positive asthma, providing they don't have rhinitis at the time, which could be influencing your figures. So you need to keep that in your mind. And you may well need to treat the nose before you even think about the airway. So think about one airway and making sure you're going the right direction. If you're pushed into peak flow, and I'm telling you, peak flow may well come out of the equation down the line, peak flow variability, you're looking at as an aptitude percentage mean of 20% or more in the diurnal variations. However, the quality of the peak flow needs to be pristine. And I have a very funny story which happened, and I didn't realize it was so bad. Over COVID, a wee girl of 16 contacted the practice, and I was able to do a video call, something like today, able to show her how to use peak flow, complaining of tightness of the chest when she was out walking with her family, da-di-da. And it sort of looked like asthma. It sounded like asthma. And again, they weren't coming into the practice at the time, but it taught me a lot. I demonstrated. I put her onto a video that we use for education, for doing good quality peak flows. And 2 weeks later, I called her to see how she was getting on. And she said, well, my best peak flow was 120 and my lowest was 80. Now, it wasn't me she needed to say, it was an undertaker, because that is not compatible with life. So I had to bring her into the surgery, have her on the ground floor outside, and she was like, not putting any effort in. I've wasted 2 weeks of her life and mine and have no results at the end of it. So we did manage to get her up to 450, but honestly, it is so badly done that it's not worthy of interpretation a lot of the time. If it's stuck for that, again, you can send them for bronchial challenges, which is not done as often now as what it used to be. I actually had a bronchial challenge, not a pleasant thing, I'm going to tell you, with methylcholine challenges in the hospital setting. It needs to be done in a hospital setting, and it's not pleasant. I had it done way back years ago, and if it would demonstrate if there's any bronchial hyperresponsiveness present. And then if that's all negative, then you have to consider an alternative diagnosis. So this is, we've just put it into a very simple pathway: pheno, blood eosinophils, spirometry, if none of the previous two are available. If that's not available, you consider with a well-taught peak flow, and if that's not available, then consider bronchial challenge testing if that's what you're left with. But you can see there, number one would be pheno, and if you can get access to that, you're home in a boat to determine whether somebody's got T2 positive asthma or not. I'm not going to labour this because I know you went through the children's before, but again, just to put everything in context, I've kept it in the presentation. And again, that's it simplified for you. And I know that the speaker on the previous occasion done a very good job. And again, I'm not going to labour the under fives, except to say that unless your under 5 is very well advanced and very cognitively developed, they cannot do a lot of these objective tests. So therefore, you're left with a suspected asthma until they're able to perform these objective testing. So you use the read code 1J70, suspected asthma, until such times as you're able to confirm that diagnosis with one of the tests that I've already mentioned there. So I've already mentioned there's lots of challenges, and there's lots of challenges. This is a brain dump just that I've done. Poor incentives in a lot of places if you're not doing QoF, although I have my own challenges with QoF. Lack of funding to get the right equipment into practice, really capacity for yourselves, education, lack of education, both in patients' perspective and indeed on our own, and patient understanding of what the disease underlying pathology is. And I've loads of stories I could tell you if I have time at the end about getting the patient to understand and come on the journey of this being a long-term problem, like a bit like, not like diabetes, but a bit like what you would consider diabetes to be a long-term problem, or indeed hypertension or any other long-term condition. So a wee bit just about the objective testing. There's a lot of different devices out there, 3 really good ones for primary care, and that'll be the No Breath, the NIOX, and the new made one, which is fantastic too. And we links there too for you that you can follow those and watch how to do it if you're not already familiar with it. We're hoping to put on our own website the use of each of these machines. We're going to do a short video which is going to be free for access, and that's Barrett McGrath EMS.com. You can go onto it. It's not up yet, but we're waiting to get the No Breath in place so that we can actually do a fair overview of the 3 of those devices. Just a wee bit about fractional exhaled nitric oxide and what it is, in case you don't already know. It is produced by the lungs and the nasal passages in greater quantities in people that have got eosinophilic inflammation ongoing. In the likes of adults, anything above 40 parts per billion, although the NICE guidelines now, or the BTSI NICE guidelines, have sort of looked at 50 and above, certainly if people are steroid naive, and greater than 35 parts per billion in young children or children. And then a positive test increases the probability of an asthma, but it doesn't, negative tests do not exclude asthma. There's a few wee sort of caveats into that. This is just something that NIOX produced a way back, and I think it's a really clear thing. Please feel free, you can download it from NIOX's website as well, but just gives you a really good, clear view of it if you're not familiar with it. But just remember, there's a few things that can interfere with FeNO. It's increased in patients with an allergic rhinitis without asthma at all. So if you feel that they've got runny nose or sneezing a lot, treat the nose first and then see how things settle down. And it may well reduce your FeNO as well. Ironically, it's increased in patients with rhinovirus, rhinosinusitis and rhinovirus. So you might want to think about repeating that again down the line if the patient isn't very symptomatic. And it's increased in tall men and in tall people, and by the consumption of dietary nitrates like lettuce and cabbage and all those kind of things. So you have to leave it 2 hours after having dietary nitrates like that. It's reduced in cigarette smoke, ironically, would you believe? Because what the patient is doing is they're increasing their neutrophils at the expense of their eosinophils. So the person that their natural eosinophilic tendency down by increasing their smoking, by increasing their nitrate or their neutrophils by smoking. So it's unfortunate, but sometimes you can get a false negative in smokers, but you can get reversibility, ironically, when you do spirometry. It's also naturally reduced by inhaled or oral steroids. That's what you're aiming for anyway. So that's why if you miss that opportunity when they come in unwell and you start them on ICS or you start them on oral steroids, you've missed that golden opportunity to actually diagnose them correctly. That's just a wee bit again about the FeNO machines that are available. The Bosch is a slightly out of our price range. I must admit the other three are probably more in line with what we do, what we're able to afford in general practice anyway. Just a wee bit, there's a wee tiny study put in there. It was done in Belfast, but I'm sure you have your own studies. But it's just interesting to see how using FeNO can impact positively your management of your patient, and when you should increase the ICS, and when it's not increased or not initiated as well. So you can have a wee look at that, or maybe look through your own local areas as well. If you're no FeNO available to you, you might want to think about taking a full blood picture and you'll get your eosinophil counts. We know that 0 to 6% of the overall white blood cells is normal, 0 to 500 cells is normal again, but you're looking for the likes of anything above 300 cells, maybe a signal towards more of an eosinophilic background in that patient, and it might be something that you want to think about as well. Note it whenever you're doing it. So the guidelines would note that 300 cells and higher when the patient is symptomatic might give you a signal that this is more of an asthma. Sputum eosinophils used to be done back in my day. I'm beginning to sound like an old woman now at this stage. And we were able to, if you could expectorate, but a lot of asthmatics, don't forget, don't bring a lot of spit up simply because they don't have access of secretions. Sometimes you can blow or cough up a little gobblety type bubbly piece of mucus that can be sent off, but it's not in the guidelines and it's not really recommended anymore. So it used to be something that we would have done years ago to look to see that. So I threw it in there for those maybe are my era and maybe wondering what has happened to that. I'm not going to labour lung function tests because I could talk about it all day, and spirometry is my big thing, and I could go through it forever. But if you're doing peak flows, make sure it's done correctly, and do not use plot the graph. Get something that they can physically write the numbers onto. And then it leaves you that you're certain whenever they write down, say 400, that they have actually measured it. And if you can see my cursor, you can see where that little arrow exactly mirrors up with that number. Even if you drop down by 40 litres per minute or something like that, which is easily done, and then plot the graph another 40, there's 80 litres per minute that's missed. So make sure to do it absolutely pristinely if you're going to do it at all. This is a wee bit about the 1 hour hypothesis. Again, I'm not going to labour that much, but just to make you aware, I've mentioned already that there's a nasoocular reflex and nasal bronchial. So always check the nose. The nose can be the caveat to upper and lower airway inflammation as well. And there's a few podcasts available. I actually did one of them with Steve Holmes on the PCRS, so you can actually access that at your leisure. So in summary to the diagnosis bit, really it is time that we all started to do a good history, good clinical assessment, the objective tests as per BTSI NICE guidelines, FeNO ideally number 1, eosinophils number 2, spirometry and good quality peak flow if you're stuck. And then a trial of treatment, still keep them on the 1J70 read code, i.e. suspected asthma. And then when you're confident 4 weeks down the line after doing a trial of treatment, ICS for Moderol, then you can confirm that the FeNO's gone down, or that they're asymptomatic, or that their peak flow stabilized, or whatever it is, barometer that you're using, and then confirm that diagnosis and put them into H33 confirmed asthma. But until we do those steps, we should not be confirming any asthma until you're absolutely sure that that's what they've got. So the key really to moving forward is to gaining an accurate asthma diagnosis using that pathway. Now, moving on to the correct management, and like we've all got paths we can choose, and paths that as healthcare professionals we can put patients onto, or paths that the patients decide they want to stay on themselves, which may or may not be correct. And we do need to educate our patients, particularly parents of young children. I'm not going to labour that, but even young people and indeed older people who think they've got it all these years. Like I get this all the time, and I'm sure you will too. SABAs are no longer recommended for asthma. Oh, for goodness sake, sure, I'm on it. That's 40 odd years. Well, we are obliged to move with the times, and the guidelines are that you should not be on that as a monotherapy, and not even using it once a week, even if you're on an ICS and fairly well controlled. So let's think about this. You wouldn't be happy about a GTN spray being used 2 or 3 or 4 times a week when somebody's got unstable angina. And likewise, if somebody's needing to use a blue inhaler throughout a week, then we've known this for many, many years, that that is a signal for poor asthma control. We now know that the blue inhaler upregulates inflammation when it's used on a fairly regular basis, and also it does nothing to addressing the underlying etiology, which I have mentioned at the very start of this presentation, which is inflammation. It does just treat the symptoms. It's nearly like giving a paracetamol to a hypertensive headache. You're treating the symptom, but you're not treating the underlying condition. So if any of those wee tidbits help you to reinforce this to your patient, that's great. So the patient has the ability to go in the wrong pathway or the right pathway, giving them the freedom, cutting those chains, getting them the freedom that they will be asymptomatic and be in control of their condition. This is another sketch I done many moons ago for PCRS to say that you can really enjoy the scenery and the cliffs, providing you stay well away from the side or the edge. And staying away from the edge means you're on the right treatment, not using SABA for intermittent relief, and being near that edge of that precipice. Because once you take any sort of insult or exposed to any trigger, you could be blown off the edge, just like Rachel Williamson was, unfortunately, using blue inhalers for hockey, using blue inhalers for this, that, done the other thing, ended up with a catastrophic asthma attack, fell over the edge, and unfortunately wasn't to be saved. So we don't want that on our conscience at all. So patients may want to have their symptoms managed, but we know that we need to manage the underlying pathobiology. So we need to educate our patients that all these symptoms that they're having are literally coming about from a red, sore chest that they may not know is there. Because remember, we have no pain sensors or cells down the air conducting passages, so the patient may be unaware of this. So we really need to educate our patient. I'm not going to go through all the different drugs and stuff like that, but this is a study that was done not today or yesterday, but back in 2013, that says SABAs treat the symptoms but not the disease. By golly, are we short as slow learners in NHS? It has taken us, what, 13 years, 12 years to really understand that we shouldn't be using SABAs in asthma, not even in conjunction with an ICS. If they're using it regularly, it's increased the hyperreactivity, they increase the inflammation and all that there. And that's known from 2006. What has been happening? We have been sitting back on our laurels and not doing anything about it. Again, I've just given all the classes of medication just for you, in case that you're new to practice, you can actually read over that. So we're going to talk about SABA and using MART and ER. MART stands for Maintenance and Reliever Therapies. It's been around for a long time, but it's really now embedded in the guidelines. There is ER now as well. It's called Anti-Inflammatory Reliever. And these are the products that are now licensed for this approach. And I'm going to just talk a wee bit about over 12s, you can use Symbicort, Fobumix, Walker, and Foster and Duress as a maintenance and reliever treatment. But just remember that from 6 to 11 now, Symbicort 100 on 6 is now licensed for MART and young children, not that young cohort. And I'm sure whoever gave the talk before me will have informed you of that. If it was out at the time that they were doing that, there's literally not long out that that MART can be used for that there. So there you again, 6 to 11 in for children from 6 to 11, just to make sure that you understand that at least in school going ages, we now don't have to send that proverbial blue inhaler into the schools every year, which is another big bone of contention because we're still feeding that wrong thing. There's a whole list of different medications that are used at different ages, etc. I have broken it all down just so that you can get that easy if you go back to that presentation. And again, a wee bit from Asthma Right Care, which I'm also in, which is a part of the PCRS. And just even shocking people to say that if you get a blue inhaler every month, it's equivalent to using 7 rescue doses per day. Like, honestly, it is shocking. And we used to think 12 was okay. Even at 6, that's greater than 3 per day. And even at 2, that's greater than 1 per day. So really do need to think about this and really stop that sort of pattern that has been going on. So the anti-inflammatory reliever therapy, known as ER, is a combination inhaler that includes corticosteroid and formoterol. Formoterol is the only long-acting beta-2 agonist that has got the license for this extra puffs, if you like, and reliever part of the management of asthma, and is prescribed in children and adults over the age of 12. Only if they get symptoms occasionally. So there may be, say, children that are maybe a little bit symptomatic in the summertime, and they're only using historical blue, dare I say it, and you're now able to give a formoterol ICS medicine that they can use when they're feeling symptomatic. If anybody asks me how I feel about it, I probably have a little bit of an anxiety about it, in that inflammation can rise quite quickly, and it worries me that it may be the case. But in certain cohorts, I have absolutely started the ER regime. And if they get, the likes of, maybe if they're going out to do sport in school or something like that, that might be when you would want to consider it. So there's the I'm going to spell it wrong there. So anybody with a quick eye there, you can see instead of anti-I, I've turned it around the other way. So apologies for that. Anti-inflammatory reliever treatments are the license, or your Symbicort 200, your Fobumix 160, and your Walker 160 as well. So this is I know it's a very busy slide, and apologies for that, but it wasn't me designed it, but it's down from the BTSI NICE guidelines. And it tells you that if you're newly diagnosed in people with asthma over the age of 12, offer a low dose ICS formoterol combination inhaler as needed. You might want to start with ER. You might then want to increase to a low dose MART, and then you might go to a moderate dose MART. I would be checking FeNO and blood eosinophils if they're still symptomatic. If things don't settle down, you may well want to consider a referral, or you may well consider an alternative diagnosis. If the patient is already existing on like a low dose ICS or a low dose ICS LABA or whatever, you can transfer them over to either low dose MART, moderate dose MART, or whatever is equivalent. If they're on a SABA only, which I hope you don't have too many of, but yeah, maybe do have a few, then consider low dose ICS formoterol as an anti-inflammatory reliever therapy. Belonging to the PCRS, of course, I'm passionate about how we simplify things to embed it in general practice. And this is your sort of pro forma, if you like, and feel free to photograph it or whatever you like, in terms of getting this new strategy embedded in children and adults and young people over the age of 12. So again, it's simplified, and you can get a lot of these sort of support tools through PCRS. If you want to join it and go on to it, you'll get all of that. This is your All Wales Adult Asthma Diagnosis and Management Guidelines as of July of this year. And it's a fantastic, well set out sort of pro forma. And you can see their asthma regime in keeping with the new guidelines, maintenance and reliever therapy, and they've broken it down into MART as well. So you can see their air as needed, and the DPIs and the use of as needed Foster and Lufrabac is supported by NICE, but it's off label on terms of their license, etc. So do not prescribe short acting beta-2 agonists. So you can see that well spelt out on your own Welsh guidelines as of July of this year. So it's a really well set out document, and I think you should really download it, have it embedded in your clinical practice as well. So I'm not going to labour that very much either, because I think it might come out in the questions, and I do want to leave. Whereas, what time is it? 11 minutes. So what way are we getting on there, guys?
Hi, Francis. If we have maybe 5 minutes or so for questions in a minute, are you nearly finished, or do you need a bit more time?
Really, there's a lot of things that they can pick up on themselves. And again, I've included, as I mentioned earlier, Andrea, I've included the children as well, but it's just for that, so that the flow goes well if they take this and read through it themselves. Now, I just want to point out that this is a read-only document. You can't reproduce this because it is copyrighted to Barrett McGrath. That's our company. And I really do just want to share it with you so that you can use it for your own learning. Please do not replicate it for, it may be out of date by the time you would go to replicate it, and I'd really rather that you would use it for your own learning. So it will be available. I'll let Andrea explain where that's going to be. Just before I finish, this is just, again, the PCRS, how you switch people from the current treatment when you're reviewing them. Don't do it obviously as a broad switch. You bring them in and you go through the device, etc., and you do their full assessment. From the age of 12, this is how you would do it, and if it broken down, and fairly, to me, it's fairly straightforward. SABA only straight onto low dose, ICS for Moderol, PRN or air, in other words, and then the rest go into either low dose or moderate dose MART. And this is just where I'm going to finish. As a good foundation, please remember, education before medication. Asthma cannot be cured, but it can be managed or controlled, and really think about what we need to be doing in terms of managing that there. So I'm going to finish at that. There's lots of other slides on that, and I'm going to stop sharing wherever you are. Wait to see if I can find just now. Here we go. Stop sharing. And I'm open for questions there. If there's any questions that have come in, Christina or Nick,
Yeah,
or
so
whoever.
just before we move ahead there, the question and answers section. So thank you, Francis. That was such a useful presentation. And as Francis said, the presentation will be shared on our website at the same time as the webinar. But there is the disclaimer that Francis just informed us of. So we do now have some time for questions. So if you'd like to ask something directly, please raise your hand or drop it in the chat, and we'll go through as many as we can before the session ends. So is there anybody who's got their hand up, or is there any in the chat?
Well,
I can see a couple of questions in the chat we can go through. So Emma's asking, how do we access pheno in primary care? And for local services, I guess we need a clinician to answer that. I'm wondering if Carwyn is there, maybe he could lend us a hand and answer that question, or we can come back to it, because it will depend on the local services available, won't it?
Yeah, and that's something that you has to reach out locally, and because sometimes it is available and sometimes it isn't. How you get it in there, it's all down to funding. So
Can I just give a wee view on it? What we're trying to do in Northern Ireland, which I'm part of the Respiratory Service Framework for Northern Ireland, it may well work in your area, is that do not buy. I wouldn't suggest you buy a Niox particularly, or the No Breath, because there's potassium permanganate in it, and it has a shelf life, the machine itself, of 5 years. So my recommendation is, if you go to one of those companies with a proposal of a long-term lease for every practice, they will reduce that cost. Now, we're getting it, we have only 306 practices in Northern Ireland, but if every one of those practices were to engage, you will get the machine and 100 tests per year for £780 or something like that. So you know, that to me, that's the most cost effective. Plus, you're not out the massive outlay of 1,800, whatever it is, to buy the machine, and therefore you bring that cost down to about 7.5 pounds per test, which is a lot less than where it started out. But you need to get a collective a collective approach, either in ICVs or whatever way you use, breaking down, or do it from a nation perspective, and that would definitely bring your overarching cost. You'd probably get it cheaper than us because you probably have a lot more practices than we have in our little province here. So it's just something to think about.
Oh, thank you, Frances. We've got another question from Natalie. Can you test FeNO during an episode of chest infection? If not, how long does it take FeNO to come down following infection to test efficiently?
Okay, that's a really good question, because I'm going to tell you, Natalie, if it's a true infection, it doesn't increase the eosinophil or the FeNO or eosinophil count. It only goes up in a response to like an allergic type response to a trigger. So patients have, and I like your question because it leads me into something else. Patients and mothers and fathers of young children, they think their children have got infections because they're coughing at night, because they've got wee runny noses and watery eyes and all of that. Remember that nasobronchial, nasoocular reflex. If that patient has got rhinitis, so they've got real true asthma, it's not infection that's putting the eosinophils up or the FeNO up. It is the inflammation that's associated with allergy. So you want to do it at the point of when they're unwell to determine, is this more infection? And if it is, then FeNO won't be affected. If it is an infection, then do their CRP, or if you can get a sample of spit, send that off to the lab. But remember, there's no reason why these young people or adults or anybody should be getting recurrent infections. And if they are, then you need to think bronchiectasis, undiagnosed cystic fibrosis, or some other underlying pathobiology that's causing that. So it's a really good question, Natalie. But unless they've got a high temperature or there's something else going on, if they have got rhinovirus, then you might want to leave it. But I would do it anyway and then repeat it again if in doubt. But certainly inflammation like that goes up with exposure to their triggers, as moreover than any other, like say COVID or like flu or anything like that. So don't be worrying about things like that.
Oh, thank you. We've got 2 more questions. Hopefully we can get through and then complete our webinar. Judith is asking, recommended reversibility drugs to be used, please. Got any advice on that?
A really good question too. So if you've got somebody that's into you today with and you've no FeNO and you've no chance of taking their blood, or they're maybe whatever, you're not keen to take their blood for whatever reason, then I would do spirometry. If you get them obstructed, or there's like a concavity in the flow volume loop, then you can give them 4 separate puffs of salbutamol at that time and repeat that 20 minutes later. Now you give them 1 puff, you give the good shake for the MDI and spacer, 1 puff, wait for a minute, then repeat that there, and then repeat it 4 times. So it should take about 5 minutes to administer 4 separate puffs via spacer, the patient blowing in nice, empty first, in nice and slowly to their full, hold that breath for a count of 5 and then exhale. And then 20 minutes later, when you've done all of that, see is there a bounce back of their FEV1 of 200 mils and 12% or more. And if you're in doubt, so say if it goes up a wee bit and you're not sure, send them home on an ICS. So all roads are pointing towards asthma. Send them home for 4 weeks in an ICS lab, preferably, so you make sure you're keeping in line with the BTSI NICE guidelines, and then repeat their spirometry in 4 to 6 weeks. Keep them on that there 4 to 6 weeks. If they're very acutely unwell, you might want to start them on oral corticosteroids, whatever dose is suitable for that age group. So as a young child, it's 2 milligrams per kilo of body weight. If it's an older child, it's 40 to 50 milligrams if they're acutely unwell, and then repeat it again. Repeat that spirometry in 5 to 7 days, really, just as soon as they finish their oral steroids. Okay. So it's different ways of doing it. I hope that answers that there.
Thank you. There's the last question we have for today is from Shan. She's asking, should we not prescribe SABA at all in asthmatics?
That is exactly right, Shan. And I'm a really bad asthmatic myself and been in intensive care twice. And if you'd have said that to me a few years ago, I'd have probably been anxious. But in the last, I'd say 8 or 9, 10 years, maybe, I do not have a SABA. I have my ICS for Moderol. I haven't had it this long time. So come from confidence, even from me. Now, young children are a little bit different. In the children that are under 5 or under 6, rather, that are not now licensed for the MART therapy, I would be thinking you probably still have to go that route. I am not going to get involved in that because I'm whoever give you that talk probably is more in tune with that than me. But certainly from the age of 6 up, that is exactly right. We could be doing more harm than good by giving out blue inhalers. And remember, if they're that unwell, they need to be in the hospital or in a clinical setting. So they can't be sitting at home puffing away on their blue inhalers, hoping to feel a bit better, because that is very, very dangerous. As in Rachel's story from Northern Ireland, I'm sure you've got your own stories in Wales as well. So yes, that the answer is no. But you might need a wee bit of time to get their confidence around that one. So just take it as you feel confident doing that.
Thank you, Frances. I'll hand over to Andrea now. Thank you.
Thank you, Christina. So before we finish, I'd just like to thank Frances once again for being here today and sharing your time and expertise.
Okay.
To Christina and Nick from the respiratory team for keeping everything running smoothly before, during and after the webinars. It's great work. Thank you both. And just a big thank you to everybody who's taken the time to join us today. I hope you found the session useful, and please share the recordings with your colleagues. You can find it on the Respiratory Matters Teams channel later today and on our website within the week. You'll find the QR code and link to our website in the chat, and feel free to share with your colleagues. And just one more reminder, if you could take the time to complete the survey posted in the chat, it will only take a few minutes, and we do listen to your feedback and want to ensure we continue improving and delivering useful, relevant webinars. Last but not least, due to the winter pressures and planning, our next Respiratory Matters webinar will not be until January 2026, and there'll be more details to follow soon. So thank you once again for joining us, and enjoy the rest of your day. Thank you.
Thank you,
Thanks.
Frances.
Thank you,
Bye.
Frances.